Bismillahirrahmanirrahim. Worthy panelists, honorable guests, and my dear fellows, Assalamu alaikum. On behalf of organizers of HAEMCON 2021, under the esteemed leadership and guidance of our chairperson, Brigadier Retired Professor Nuzhat Mushahid, and President, Pakistan Society of Haematology, Major General Retired Professor Parvez Ahmed, Hilal-e-Imtiaz Military, I welcome you all to the very first and unique learning experience, the virtual HAEMCON 2021. I am Major Dr. Sunila Tashfeen, Classified Haematologist, and I am working as Assistant Professor of Pathology at Army Medical College, Rawalpindi. I will be the moderator of this scientific session 2, which is on hemostasis and thrombosis. Let me introduce the panel members of this session. Our first panelist is Professor Dr. Major General Retired Mohammad Ayyub, Hilal-e-Imtiaz Military. He is a graduate of Khyber Medical College and completed his fellowship from UK, and after that completed Doctor of Philosophy from London in year 1994. Second panel member is Professor Dr. Tahira Zafar, a graduate of King Edward Medical College. She has completed her MRC Pathology and FRC Pathology from substantial training at premier medical institutions in London, St. George's Hospital School and Royal Free Hospital. She is a founder of Hemophilia Patients Welfare Society Rawalpindi and also established Hemophilia Treatment Center in PIMS, Khyber Pakhtunkhwa, Azad Jammu Kashmir, Northern Punjab and Afghanistan. At present, she is a director and chairperson, Medical Advisor Board of Hemophilia Patients Welfare Society. Our third panel member is Associate Professor Munira Borhany. She is a graduate of Sindh Medical College and completed MCPS and FCPS Hematology in year 2007. She is the first Pakistani recipient of International Society of Thrombosis and Hemostasis Fellowship from Milan, Italy. At present, she is working as Associate Professor and Consultant Hematologist at National Institute of Blood Disease and Bone Marrow, as well as at Dr. Ziauddin Medical Hospital. Ladies and gentlemen, we have 6 speakers in this session from Pakistan and abroad. And duration of this session would be 130 minutes, which will be followed by a question and answer session and panel discussion. I would request speakers to adhere to the time slot given to them, and please frame your questions well to have maximum questions in given time. Thank you. Our first speaker is Dr. Shabneez Hussain, graduate of Aga Khan University. She is the medical director at Fatmid Foundation, Pakistan, and has special interest in thalassemia and hemophilia. Today, the topic of her talk is clinical outcome of fibrin glue in managing intractable gingival bleeding in patients with inherited bleeding disorders, a case control study. Over to Dr. Shabneez.
Thank you so much for the kind introduction. I'll just share my screen. Right, I hope my screen is visible to all of you. Right, so I have no disclosures. A brief introduction. Proper oral and diet dental hygiene is of utmost importance in patients with inherited bleeding disorders. Because of this, they have intractable gingival bleeding. Anatomically, gingiva has thin blood vessels, because of which it bleeds when they brush their teeth, or if there's an abrasion by food, or if there's a secondary periodontal disease. Inflamed gingiva, it has a high fibrinolytic activity due to the presence of fibrinolysis activators in oral epithelial cells and saliva. Again, another contributor of gingival bleed. So in Pakistan, there's a very limited number of hemophilia treatment centers, and majority have constrained resources. We have shown in our previous study, which was from which was data based on all of Pakistan from Fatmid Foundation, that majority, 76% of the patients have mucocutaneous bleeds, and they all require blood transfusion. So when you talk about mucocutaneous bleeds, it may be preventable if it's taken if the patients are counseled from the beginning. Available local hemostatic agents usually present in the thalassemia centers, it's transamine, tranexamic acid, or epinephrine and tranexamic acid, so gauze swabs, and also Fibrin glue. So this was the background of the study. Now the problems we have in our center, the problems are that in patients with bleeding disorders, their problem is that they avoid toothbrushing because of the risk of gingival bleed, and they're scared. Because of the fear, they have a poor oral hygiene, and that leads to recurrent gingival bleeding, which may be severe enough in causing iron deficiency. So these patients then require iron supplementation, and if that doesn't work, then they have to be given blood transfusion. Usually, patients avoid doctor's consultation for minor ailments in a lower middle class income, in a lower middle income country. So, and on the flip side, if the patient does seek dental treatment, what happens is that there are delays because there is a lack of dentists net this experience in treating bleeding disorders and providing prompt dental care. Right. So what is fibrin glue? Fibrin glue is a topical adhesive that can be prepared from cryoprecipitate, bovine thrombin, and calcium. There have been various reports of its role in arresting bleeding in circumcision and dental extractions, and it also reduces hospital stay, utilization of blood components, and and the utilization of factor concentrates. So we needed to see how it can work in our setting. So the objective of our study was aimed in evaluating the clinical outcome of fibrin glue in managing intractable gingival bleed in patients with inherited bleeding disorders. Our patients, so if you look at the chart, we chose inherited bleeding disorder patients with acute oral bleeding, which is less than or equal to 7 days. We did their complete blood count and ferritin levels at initial visit. If the hemoglobin was less than 8 grams, we optimized them by transfusing them packed red cells and maintain their hemoglobin above 8 grams. And we divided the patients in 2 groups: those who were given fibrin glue and those who were not given fibrin glue. In both patients, both groups were followed for 7 days. During that 7 days, they were transfused with blood components, FFP, cryoprecipitate, and platelets. They were also given ferrous sulfate, iron supplement. They were counseled and referred for dental evaluation on day 1 of being inducted in the study. Additionally, we used tranexamic acid gauze swabs also. Then we assessed these patients on alternate days at the hemophilia treatment centers for 1 week. Then these patients were followed up for 1 year for any recurrent oral bleed. The setting was Patni Foundation Karachi Center. We did this study from May 2018 to 2019, and we used non-parametric statistical tests for data analysis. This was a way in which we prepared cost-effective, because we needed a cost-effective method. So we actually prepared this in-house, in which you can see 2 syringes. One has cryoprecipitate and the other has thrombin and calcium solution in the syringe. And we joined both syringes, and then we applied on the patient's gingiva. What were our outcome measures? Our outcome measures were the number of transfusion days. So each day of patient being transfused at our center was counted as 1 day. Secondly, we assessed the consumption of blood components during those 7 days for which the patients was admitted in our center or visited our center. The third was compliance for dental evaluation, since all patients were referred and advised to go for dental evaluation, because that was the main problem in the beginning. Nobody was going for dental evaluation and they preferred blood transfusions instead. So we assessed dental compliance, how many of them complied. The fourth was gingival bleeding during assessment period. So once we started treating those patients, we saw how many of the patients they had gingival bleeding after started treatment. How many of them had a persistent gingival bleed, and how many of them had a stoppage of the bleed after the initiation of treatment. Then these patients were followed up for 1 year, as I said previously, and then we saw the recurrence of gingival bleed during that period, as in how much time did it take for the patient to come back again with another oral bleed. So in results, we had majority of the patients were they were almost equal, but majority were males. There was so one was our intervention group and one was our control group, and this was not a significant difference between both groups. The age, they were mainly adult patients. Education, again, majority had a higher school or lower education, but there were majority of the patients were in the control group who were less educated. In the intervention group who were less educated. Then we did an ISCH BAT score in which we saw how severe the bleeding is. So almost both groups had the same severity of bleeding. Third was the diagnosis. So we had patients with Glasgow thrombocythemia, we had Borhany band disease, and we had hemophilia A. In Glasgow thrombocythemia, of course, there was no subtyping, but in Borhany band disease, majority of them were type 1 and type 3. In hemophilia A, majority were mild hemophiliacs. Then we saw the hemoglobin difference in both groups. So we saw that in the intervention group, there was a slightly lower presenting of a lower hemoglobin range compared to that of intervention group. Ferritin was lower again in the intervention group. Iron deficiency anemia was present almost equally in both groups. Right. So our outcome measures, which is the main outcome of the study, we saw that in the group with intervention, there was a lesser utilization of blood components compared to that of the control group, and this was highly significant. Secondly, the utilization of platelet, cryoprecipitate, and FFP. So the main blood component, which is very important in our center, is cryoprecipitate. We really need it for patients who have hemophilia A, joint bleeds, and everything. So we saw that when we used Fibrin glue in our intervention group, we saved more packed red cells, and we saved more cryoprecipitate. Secondly, there was a higher number of patients, although not significant, but they complied for dental evaluation. So we actually saw that our intervention may have worked at some level. Rest of the outcome measures were not that significant, but we saw that there was no lesser persistence of dental bleed after intervention in the intervention group. And there was also a lesser number of recurrence of oral bleed in the intervention group. Secondly, the interval, which is also important. So after these patients were treated, there was almost a very significant difference of these patients having the next oral bleed, but that was in the control group. So this was the picture that we actually got. This is how bad their gums were. You can see calculi, you can see caries, you can see a lot of gingival swelling, and they have stones in their teeth because of lack of brushing. So these were the findings that were very common, because those patients who actually went for dental evaluation, we actually started looking at their findings, and we saw that hemophilia, as you can see, there's a higher number of patients who went for dental evaluation. Mainly, these patients were Glasgow thrombocythemia. Secondly, findings of dental evaluation. Now, if you look at the arrows, these are the arrows which are significant findings in this table. So you can see all patients had poor oral hygiene. Majority, almost 100% patients, 100% patients had generalized gingivitis. All patients had plaque formation in their teeth, and they were all given oral hygiene instructions. They were given, scaling was done on all of these patients. They were given antibiotics, there were antiseptic mouthwashes given. So on the basis of this evaluation, these patients were treated as well. So our study demonstrated that the utility of Fibrin application in reducing blood component consumption, and also reducing the number of transfusion days in patients with inherited bleeding disorders. Although it was not significant, but it was there. Like in the intervention groups, this transfusion day was 2 days, but in the control group, the transfusion days were 2.5 days. But there was some sort of difference. Secondly, there were no similar studies which have been published regarding this. So we could not compare our results to other studies. And additionally, it was noted that also it is statistically insignificant. Our main outcome was that patients actually go for dental evaluation. Our limitation was that we had a small sample size. There was so caries may be a compounder. Secondly, Fibrin glue has a poor taste. So because of poor taste, patients did not like it, that if we plan to reapply the Fibrin glue, so they did not like it. It has a very bad taste. Secondly, there was no long-term follow-up. These patients really needed that. Another thing is the transmission of transfusion-transmitted infections that need to be assessed. And there's a risk of parvovirus B19 infection, which has been reported in 20% of patients with inherited bleeding disorders. So to conclude, application of Fibrin glue. So in developing countries, they use laser diode, which is present in their clinic, and they actually seal all the blood vessels right there in their clinics, and they get this window period in which they treat the patients. In our study, we used Fibrin glue because it was already available in our center, and we saw that it really did work in our patients. Secondly, what we actually we came to a conclusion that we need to do primary prevention, and we need to strengthen the role of regular visits to the dentist when we when we actually registered the patient in our organization for the first time. So that is an important thing. Right. So thank you. With that, I would like to end my presentation. Thank you so much.
Thank you, Dr. Shabneez. Now, our second speaker is Dr. Razia Asif, resident of MPhil Hematology in Liaquat University of Medical and Health Sciences. Topic of her paper is the significance of platelet factor 4 antibody in diabetic and non-diabetic population during heparin therapy in Pakistan. Over to Dr. Razia. Kindly adhere to your time. Your allocated time is 10 minutes.
I'm Dr. Razia Asif from Department of Pathology, Lungs, Jamshoro, Diagnostic and Research Laboratories, Hyderabad. I'm going to present my research work, the significance of platelet factor 4 antibody in diabetic and non-diabetic population during heparin therapy. These are the contents of my study. I have nothing to disclose. Introduction. Diabetes mellitus is a clinical syndrome characterized by hyperglycemia caused by absolute or relative deficiency of insulin. These findings support the concept that diabetes mellitus can be associated with a hypercoagulable state, which can be potentially exacerbated in patients with overt arterial disease for those who have undergone conventional therapy. Heparin used for thromboprophylaxis and treatment in several clinical disorders. The use of heparin in clinical disorders is unfortunately associated with various complications. Among them, hemorrhage is the commonest, while others include osteoporosis, heparin-induced thrombocytopenia, and alopecia. Heparin-induced thrombocytopenia is a life-threatening complication and requires highly prioritized management. Heparin-induced thrombocytopenia is a life-threatening complication and requires highly prioritized management. Rationale of my study: to assessment of the burden of disease and early diagnosis to prevent from lethal complication of patients which are on heparin therapy. Objective of study was to evaluate the severity of thrombocytopenia in diabetic and non-diabetic population during heparin therapy. This cross-sectional study conducted was in Department of Pathology, Lungs, Jamshoro under the period of 6 months. We include the diabetic and non-diabetic patients who are already on heparin therapy for 1 to 7 days despite any clinical disorder, 18 to 70 years of age and both gender, and exclude the diagnosed cases of malaria, viral hemorrhagic fever, hemolytic anemia, malignancy, and DIC, and known cases of ITP, patients who are already on drug affecting platelet count. In data collection procedure, we selected diabetic and non-diabetic individuals receiving heparin therapy who are admitted in different wards. Then, after taking detailed clinical history, we took 5 ml venous blood sample in EDTA tube, divided in 2 tubes, and CBC done by using 6-max XM 1000 diet, and follow patients on alternate days up to 7 days who are on heparin therapy. It was considered if platelet count decreased below 150,000 per microliter or more than 50% of baseline. CBC was, HbA1c was performed, Arkley Adams A1c light, and platelet factor 4 antibodies by IDPAG IA antibody kit. Now the results. Analysis of data was done by SPSS version 22. This result showing the gender and age distribution. Total number of patients were 173. 58.8% were male and 42% were female. The mean age of the diabetic and non-diabetic patients were the same. And this result showing the 80.6 diabetic patient with developed mild thrombocytopenia, while the 19.3 diabetic patient were moderate. And out of the mild thrombocytopenia, 33.8% were developed platelet factor 4 antibodies, while the 38.7% positive factor 4 antibodies. And this result showing the severity of thrombocytopenia, 80.60% were the developed mild thrombocytopenia, while the 19.30% were moderate. Again, this result show the 46.2% diabetic patient were developed thrombocytopenia and 53.8% were non-diabetic. And in this result showing the platelet factor 4 antibodies, 63 individuals who are developed factor 4 antibodies and others 1 negative. The discussion, 71.4% diabetic patients developed thrombocytopenia in current study, and the study done by Jocelyn Diaz et al., 49.57%. In current study, 36.4% developed platelet factor 4 antibodies, and a study done by Salter VS et al., 38.6%. 29.6% non-diabetic patients developed thrombocytopenia, and the study was done by Warkentin T et al., 28.64%. In the conclusion, the study resulted in male gender predominance and it was discovered in diabetic population. Mild to moderate low platelet count were comprehended in diabetic patients. Platelet factor 4 antibodies were positive. Limitation of this study, lack of follow-up due to most of the patients from remote areas, and larger prospective studies are needed to evaluate true dimensions of the disease. I have some suggestion for future. Early diagnosis or detection of platelet factor 4 antibodies may be helpful for those who are at risk will be managed properly and prevented from lethal complications. It should be treated with alternative anticoagulant therapy to reduce complication. Careful follow-up of platelet count may be identified patients who will eventually develop with antibodies. I acknowledge all co-authors who supported in collection of sample and take part in the study, technical staff and IT team of Diagnostic and Research Laboratories, Lumps Jamshoro, and all members of Pakistan Society of Haematology. Thank you.
Thank you so much, Dr. Razia. Our next speaker is Dr. Maymoona Suhail, Resident Hematology at Armed Forces Institute of Pathology. She will present her paper on investigating inherited causes in patients presenting with thrombophilia. Your allocated time is 10 minutes. Thank you, Dr. Maymoona.
Bismillahirrahmanirrahim. I am Dr. Maymoona Suhail, Resident Hematology, Armed Forces Institute of Pathology, and I will be presenting my study on inherited causes in patients presenting with thrombophilia, study in a tertiary care center. Thrombophilia is defined as an abnormality of the coagulation or fibrinolytic system that results in a hypercoagulable state and increases the risk of an individual for a thrombotic event, in which intravascular thrombus formation may be arterial or venous. Virchow-Striat, described in 1859, postulates that venous thrombosis results from a complex interplay of alterations in blood flow, vascular endothelial injury, and inherited or acquired hypercoagulable state of the blood. Causes of thrombophilia may either be acquired or hereditary. Acquired causes include inevitable environmental factors like increasing age, pregnancy, prolonged immobility, obesity, smoking, trauma, and others. While the inherited causes include protein C deficiency, protein S deficiency, antithrombin deficiency, factor V Leiden mutation, or prothrombin gene mutation. The coagulation and fibrinolytic systems are two separate but linked enzyme cascades that regulate the formation and breakdown of fibrin. The pathways function as a series of positive and negative feedback loops, thus maintaining a delicate balance. From the statistics of the Western population, among the inherited thrombophilias, factor V Leiden mutation is the commonest mutation in the general population, while the relative risk of developing venous thrombosis has been seen more with antithrombin, protein C, and S deficiency. Protein C is a vitamin K-dependent anticoagulant protein. It circulates as a zymogen and exerts its anticoagulant function after activation to activated protein C, a serine protease. The primary role of activated protein C is to inactivate factor V and factor VIII, which are necessary for the efficient thrombin generation and factor X activation. The inhibitory effect of activated protein C is enhanced by protein S, another vitamin K-dependent anticoagulant protein. Antithrombin is a serine protease inhibitor that plays a significant role in the process of anticoagulation by interaction with its cofactor heparin. Antithrombin inactivates thrombin directly and also inactivates factor 9, 10, and 11 by forming a covalent complex. Prothrombin is a precursor of thrombin. The G20210 8-point mutation results from a substitution of adenine for guanine in a non-coding region of the gene, resulting in increased risk of venous thromboembolism. Factor V laden results from point mutation of factor V gene and renders factor V insensitive to the actions of activated protein C. Thus, individuals are at increased risk of thrombophilia. Now I come to my study. The objectives of my study are to review the different causes of inherited thrombophilia and to evaluate different clinical presentations in patients presenting with documented venous or arterial thrombosis. The study was carried out in Department of Haematology, Armed Forces Institute of Pathology for a period of 3 years. Patients with documented thrombotic event of all ages and both genders were included, while patients on anticoagulation and those diagnosed with hyperhomocystinemia and dysfibrinogenemia were excluded. Global clotting-based screening test was used to determine the anticoagulatory capacity of protein C and S on automated coagulation analyzers CS5100 using Siemens Global kit. Ratios less than 0.8 warrants testing for protein C and S activity. If Global screening test was positive, then chromogenic assay was done for functional protein C and clotting-based assay was done for protein S. Quantitative determination of the functional activity of antithrombin was performed on CS5100 automated coagulation analyzers using Siemens Berry-Chrome antithrombin kit. Activated protein C resistance assay using factor V deficient plasma was performed to screen the factor V laden mutation. Patients having ratio less than 0.8 were further confirmed by PCR for FVR506Q mutation. Patient samples were run in duplicate along with positive and negative controls. Zygosity was determined by conventional PCR followed by gel electrophoresis. Real-time reverse transcriptase PCR assay was performed for prothrombin G20210A mutation on Cepheid Gene Expert. Data analysis. A total of 2,490 patients with documented thrombophilia were screened for inherited causes over a period of 3 years. Among them, only 7.8% were found to be positive for inherited thrombophilia. Median age was found to be 28 years, and inherited thrombophilia was most commonly seen in 15 to 30 years age group. The gender distribution was almost equal. The distribution of clinical features in our group of positive patients is shown in this pie chart, which highlights that DVT was the most common presenting feature, followed by pulmonary embolism. There was no statistically significant association seen with family history. Factor V laden mutation was the commonest cause of inherited thrombophilia in our group of study. Of all the patients diagnosed with inherited thrombophilia, factor V laden mutation was the most frequent and was detected in 56% of this cohort, followed by antithrombin deficiency in 23%, protein C deficiency in 16%, while protein S deficiency was detected only in 4%, and prothrombin gene mutation only in 1%. 96.3% of the patients with factor V laden mutation were heterozygous, while 3.7% were homozygous, whereas both patients harboring prothrombin gene mutation were heterozygous for the mutation. Patients with protein C and S deficiency presented at an earlier age, while antithrombin and factor V laden were seen in all age groups. The patients were also stratified according to gender, and there was no statistically significant association seen. This is a graphical representation of the different thrombotic events stratified according to the detected underlying inherited tendency. This line graph represents the protein C levels of our cohort of patients. The mean protein C level was 15.9 international units per deciliter. Mean protein S levels were 7.75 international unit per deciliter, while mean antithrombin level was 11.4 international unit per deciliter with a wide range of from 1 to 31. The frequency of factor V laden mutation was 4.3% in our group of study, which is comparable to a frequency of 2.2 in the Saudi population. However, data from the Western studies have reported much higher incidences, whereas our antithrombin levels are comparable with that of Italian and American study. On the contrary, the frequency of protein C and S deficiency as well as prothrombin gene mutation were much less as compared to the international data. Ladies and gentlemen, the conclusion of my study is that inherited causes contributed 7.3% of the patients with thrombophilia. Genetic causes, though rare, may be a significant underlying risk factor for a thrombotic event. And inherited thrombophilia in combination with acquired thrombophilic risk factors, which may be transient or persistent, may lead to thrombotic event at a younger age. In the end, I would like to thank you all.
Thank you, Dr. Maymoona, for such a comprehensive talk on thrombophilia and its causes. Now I will ask Dr. Shahzad Nasir, who is a graduate of Rawalpindi Medical College and completed fellowship in clinical hematology. At present, he is working as consultant hematologist and bone marrow transplant physician in Quaid-e-Azam International Hospital. His topic is anticoagulation in venous thromboembolism, when and how to stop. Over to Dr. Shahzad.
Thank you very much, PSH, for giving me the opportunity. Topic is anticoagulation and its duration. I have no conflict of interest to declare. My basic aim of presentation is why to anticoagulate, risk of anticoagulation. We'll talk briefly about duration of anticoagulation, how to stop anticoagulation, and at the end of the presentation we will take some home messages, hopefully. Aims of anticoagulation is we have to decide why we are anticoagulating. The primary objective of anticoagulation is basically we start in cases of deep venous thrombosis. Aim is to prevent a pulmonary embolism, to reduce morbidity, and prevent or minimize the risk of post-thrombotic syndrome. Anticoagulation reduces the risk of recurrent VTE during the first 3 months from 25 to 5% based on different studies. To reach a proper diagnosis of VTE, we need to have a proper diagnosis. In a resource-poor country like Pakistan, I would like my fellows and my junior colleagues especially to be sensitized about a risk stratification and taking it a proper diagnosis. One of them is a Wells Clinical Prediction Guide, which quantify the general probability of DVT. It enables us, a physician, to risk stratify the patient. Either they are moderate or high or low risk categories. This is the probability of VTE in any patients which you are dealing with. So it will cut the price, the diagnosis probability will be more specific. Whenever we are anticoagulating, we should know the limitations of anticoagulation. It will only inhibit the propagation. It does not remove the thrombus. It is the basic concept. And it will not reduce the post-thrombotic syndrome based on different studies. And there is a variable risk of significant bleeding is there whenever you are anticoagulating. In 2 to 4% of patients with DVT, they progress to symptomatic pulmonary embolism despite anticoagulation. So there is a chance of failure of anticoagulation also. And in the setting of PE, 8% of patients will have recurrence of pulmonary embolism despite on anticoagulation, and 30 to 40% of this second pulmonary embolism will be fatal. The main adverse effect of anticoagulation will be bleeding or thrombocytopenia, especially if they are on heparin or in heparin. Almost 2% of the patient experience major bleeding within the 3 months of therapy, and 1 to 3% thereafter per year. And the estimated fatality rate of each of these episodes is about 13%, and that is evident by the different studies. And HIT is already addressed by my previous speaker, so I will not go much in details. There is a very interesting studies based on the duration of anticoagulation. There are 5 randomized trials compared 4 to 6 weeks of anticoagulation versus 3 to 6 months of therapy. And if you go into the meta-analysis of these findings, they find that the shorter course of therapy was associated, which is 4 to 6 weeks of anticoagulation, was associated with about 2-fold increase in the recurrence during the first 9 to 24 months. And follow-up included the period of group 1, which was off anticoagulation. An analysis of these patient data from these 4 trials, they demonstrate that the risk of recurrence of stopping anticoagulation in early was treated for 4 to 6 weeks was more in the initial 3 months. If you stop anticoagulation after 4 to 6 weeks of giving therapy, initial 3 months will have more chances of having thrombosis. And then the recurrence of 4 to 6 weeks compared with 6 months of stopping therapy, and in those with the DVT with extra recurrence came in the same leg as the initial event. So that data basically indicates that the 4 to 6 weeks of anticoagulation is insufficient for active treatment, and support of this concept of early recurrence offer you the inadequate suppression of coagulation at the initial site of thrombus. There are 4 randomized trials which have compared between 3 months to 6 months of anticoagulation. So meta-analysis of these found a similar recurrence of rate if you compare between 3 months and the 6 months of anticoagulation in 1 to 2 years of follow-up. And an analysis of these patients from these 4 trials and another study that compared between 3 months of anticoagulation with 27 months of anticoagulation also found no convincing increase in the in risk of recurrence after initial treatment. So basically here, these data showed us that 3 months of anticoagulation is long enough to complete an active treatment. However, in real world, there is nothing called one size fits all. The most important consequence of recurrent VTE or major bleed that it may be fatal, that we have to remember. And in case fatalities has been estimated as 3.6% for recurrent VTE and 11% of major bleed if patient is on VKA. Fatal PE, we have to remember that it occurs more often outside the prospective analysis, and 11.3 estimate of case fatality of major bleed is based from the data from initial rather than extended therapy. And we have to remember, if you do a longer anticoagulation, non-fatal events are also important. That PE and DVT and bleeding are all distressing for the patient and they're costly. Recurrent VTE, especially in the same leg, increases the risk and the severity of the post-thrombotic syndrome, and recurrent PE may cause chronic cardiopulmonary impairments. So now the question will come, which patient should stop anticoagulation at 3 months and which should remain on anticoagulation indefinitely? This decision is basically dominated that which patients have the higher risk of recurrent VTE, which patient have a high risk of bleeding. So within the low risk of recurrent VTE, for example, patient who has a recurrent or reversible provoking factor, anticoagulation should be stopped at 3 months until and unless, even if the bleeding risk is low. So these patients, you should stop anticoagulation at 3 months. Patients who are high risk of recurrent VTE, for example, patient with cancer, anticoagulation should continue even if the bleeding risk is a little higher. With the exception of advanced age, risk factors for bleeding are not common in patients with unprovoked VTE, the subgroup in whom the bleeding risk is most influential. And the risk of bleeding up till now is difficult to predict by different studies. Which patients, again, we are discussing about the recurrent venous thromboembolism in individual patient if the anticoagulation is stopped. If VT is provoked by a major reversible factor, for example, if it is a recent surgery, they have a very low risk of recurrence that is estimated to be 1% within 1 year and 3% within the 5 years of stopping treatment. If the recurrence in a patient is provoked by a non-surgical trigger, for example, estrogen therapy, if she has pregnancy, leg injury, or a flight of longer than 8-hour duration, it is high in the patient with VT provoked by the surgery. The risk is still low, and it is estimated to be within 5% for the first year and 15% within 5 years. However, we have to remember an important thing is if it is an unprovoked venous thromboembolism for which there is no apparent or initial trivial factor, they have a moderately high risk of recurrence, and it is estimated to be 10% within first year and 30% within 5 years. So these are the patients you have to remember. If they don't have any reasons to have a venous thromboembolism, they are the highest risk of having a recurrent VTE. VTE provoked by a persistent or progressive factor, for example, cancer patients, they have a high risk of recurrence, perhaps equivalent to 20%. If you compare it with the unprovoked is 1%, and with the cancer, they have a 20% chance that they will have a recurrent VTE. However, it is to be expected to be lower chances if cancer is in remission, and it is higher chances depend on the cancer if it is progressive or metastatic. Or patient on chemotherapy will have a higher chance of having VTE. And another important evidence which is proven by our studies that men have a higher risk of recurrence than women. 1.5 to 2-fold increased chance that men will have higher recurrence. Patients who have a positive D-dimer, especially after stopping anticoagulation, will have a higher chance of having recurrent VTE, 1.5 to 2.5-fold increased chances. Another factor which is associated with recurrence is antiphospholipid syndrome. Relative risk is almost 2%. Hereditary thrombophilia, Asian ethnicity. It was, and if there is ultrasound evidence of residual thrombosis in the proximal vein, they will have increased chances of a recurrent VTE. So there are some clinical predictions rules which have established to estimate the recurrence of unprovoked DVT and their recurrence, and they do take into account combination of sex, D-dimer levels, and the site of initial thrombosis. So they will have the ability to predict the outcomes. What are the problems we face if we continue to continue the anticoagulation for a longer duration? They will have major bleeding chances if older age, more than 65 years, particularly age more than 75 years. And if they have a previous bleeding, if they have cancer, if they have renal insufficiency, renal failure, diabetes, concomitant antiplatelet therapy. So, you have to take into account the patient's perspective and patient's history, that these patients will have a higher chance of a bleeding risk factor. And with an increase of severity of individual factors and the number of factors present, the risk of bleeding is expected to increase. However, there is no validation prediction rules which we still have that we can pretend we can say for definitely that these patients will have an increased chance or increased chances of bleeding during extended anticoagulation. That's the consideration. I'm sorry for a busy slide, but let us go for our recommendations or guidelines that patient with a first unprovoked proximal DVT and a PE who do not have a high risk of bleeding are expected to have a modest mortality benefit from the extended therapy. This is a weak recommendation which you have to take in account, as the rate of recurrence is expected to be higher in males than women, and patient who have PE is more likely that he will have a recurrence. So being a male or having a PE will strengthen the argument for having an indefinite or longer duration of anticoagulation. As I have shown you in the slides previously, that D-dimer levels a month after stopping anticoagulation can help us to predict the risk of recurrence in a patient with the first unprovoked VTE. So these patients with a positive D-dimer can have a higher or longer duration of anticoagulation. However, because these findings are still preliminary, it appears acceptable to discuss with the patient and take into his consent and his approach that how you are going to anticoagulate based on D-dimers. That's a slide. I took it from the latest guidelines from American Society of Haematology, and that's in the tabulated form that how the duration of anticoagulation is taken into account. Cancer patient, D-dimer positive, and the distal pulmonary embolism or a distal venous thrombosis. If the first unprovoked venous thromboembolism is an isolated distal DVT, the risk of recurrence is estimated to be low enough, 5% in the first year, and it justifies stopping anticoagulation at 3 months. Especially if the bleeding risk is high, you can stop the anticoagulation. If it is second or subsequent episode of unprovoked VTE, the risk of recurrence is estimated to be high enough, 15% in the first year and 45% in 5 years, and this justify the indefinite anticoagulation, provided there is no risk of bleeding. The predictive value of patient sex and post-treatment D-dimer has not been evaluated in the event of second venous thromboembolism. However, patients with venous thromboembolism and cancer have a high risk of recurrence, and they're expected to derive benefit from the extended anticoagulation therapy. Anticoagulation, as we all know, is usually with the low molecular weight heparin, and it's shown as a mortality benefit. Anticoagulation can be stopped if patient has been treated for at least 3 months and cancer is thought to be cured, especially after a successful resection. And however, if it is there is uncertainty, our practice is to continue treatment for 6 months, which have passed without recurrent disease. If cancer is in remission but not cured, there is indirect evidence of low risk of recurrence. And in absence of metastasis, patient not receiving chemotherapy, and if it is a distal DVT, this is a reasonable practice to stop anticoagulation in these patients. In addition to considering the usual consideration, we avoid using the new oral anticoagulants patients who are receiving chemotherapy up till now. You have to keep in mind patient preferences and cost. Some patient resents where other are rescued by the anticoagulation therapy. So we have to keep in mind whenever we are treating about patient preferences, and it should influence our decision making, especially when there is a weak recommendation for an indefinite therapy. However, patient needs to be informed of the risk and benefits with the difference of different opinions and options and areas of uncertainty. Healthcare providers should be prepared to say which option they think is the best and to explain why. Because sometimes patients want the expert opinion, cost, that is the patient to the healthcare system and a third-party payers, and available treatment options may further influence decision at the patient and the society level. Antiplatelet therapy in venous thromboembolism is that after anticoagulation for unprovoked VTE, aspirin reduces the risk of recurrence by about 1/3. However, it is not a significant reduction if you compare it with proper new oral anticoagulant agents or the other forms of treatment. However, they do carry almost a similar risk of bleeding with aspirin and new oral anticoagulants. If you compare, the risk of bleeding will be the same. So benefit is less, but the risk of bleeding is there. So antiplatelet therapy doesn't come without a price, especially if you compare for venous thromboembolism. What happens if you put a patient on extended therapy? How we should follow up? We need to follow them up regularly to see if they have not developed any contraindication to the anticoagulation therapy, if the patient preferences has not changed, and they can avail improved ways, or if we got new evidence or new possibility of safely stopping the anticoagulation, and they are being treated with the most suitable anticoagulation regime if new agents have come up. So that's the aim of following up a patient on extended therapy. What are our recommendations of anticoagulation resumption after a major bleed? So resuming anticoagulation, especially following a GI bleed or intracranial hemorrhages, if you review the data, they reduces the all-cause mortality. That's a very important take-home message, with a relative risk of 0.62% and 95% confidence interval. 165 fewer deaths per 1,000 patients. And they have a reduced risk of thromboembolism. So resuming anticoagulation after GI bleed or intracerebral hemorrhage associated with increased risk of major bleeding. Almost 43 more bleeding events per 1,000. So basically, there is a chance of major bleed even with the resumption of anticoagulation, but there is a mortality benefit and there is a reduced risk of thromboembolism of resumption of anticoagulation after major bleed. However, the timing is still not very clear. Most of the practices is reasonable to wait for at least 2 weeks, but not more than 90 days or 3 months time. Then we have to restart or thinking about resuming of anticoagulation after a major bleed, either intracerebral or GI. So this is a recommendation from ASH clinical practice guidelines that resuming anticoagulation within 90 days is shown a mortality benefit. That's my presentation, and thank you very much for listening to me.
Our next speaker is Dr. Raheel Iftikhar, graduate of Army Medical College. He has completed his first fellowship in medicine in 2012 and then second fellowship in clinical hematology in 2018. He is a consultant clinical hematologist and transplant physician at National Institute of Bone Marrow Transplant Center. Today, he will enlighten us about COVID-19 coagulopathy, state of knowledge. Over to Dr. Raheel.
Thank you very much. First of all, I would like to thank the organizers for inviting me here today. After its first documentation in Wuhan, China, COVID has affected more than 102 million population around the globe. And most of the countries, including Pakistan, are now fighting second wave. We have recorded more than 5 lakh cases of COVID in Pakistan with a death toll of around 12,000, and it is continuously increasing. The disease presentation of COVID is actually heterogeneous. On one spectrum, there are patients who are asymptomatic or who have mild disease. And on other spectrum, there are patients who have multi-organ dysfunction syndrome, they have got ARDS, and they are critical enough to be admitted in ICU. The clinical presentation of COVID is actually myriad. If you see, there is actually virtually no organ system that is spared from COVID, and hematology is no exception. What we have seen in our clinical practice is that those COVID patients who have got some hematological abnormality, they virtually fall in severe or critical category. And the prognosis, as we will discuss ahead as well, is directly proportional to our hematological involvement. We know that as per surviving sepsis guidelines, any patient who has got a documented source of infection and a SOFA score of 2 or more, they are said to have sepsis. So in the scenario of COVID, most of the severe COVID patients meet the sepsis criteria. And we know that any patient who has got sepsis with one or more organ dysfunction, they are said to have severe sepsis. And most of the critical COVID patients have got severe sepsis. This sepsis actually then triggers a clinical spectrum which is known as sepsis-induced coagulopathy. This sepsis-induced coagulopathy is actually a continuum, starting from the infection, proceeding to sepsis-induced coagulopathy, and actually culminating in DIC and frank hemorrhagic complications. If you see, the first actually trigger is the infection, which in this case is infection by SARS-CoV-2, which causes trigger and release of pathogen-associated molecular patterns. These pathogen-associated molecular patterns, these one, then causes stimulation of mononuclear cells, release of pro-inflammatory cytokines, and in turn leads to activation of coagulation cascade, resulting in widespread disseminated fibrin deposition. So this is the stage which is actually stage of sepsis-induced coagulopathy, and which we'll study further is actually a hypercoagulable state. If we do not intervene at this time, then there is progression of the disease, and the disease progresses from sepsis-induced coagulopathy to frank DIC. So for patients of COVID who have got this coagulopathy, the term COVID-associated coagulopathy or also known as CAC is used. It is important to recognize that this CAC is actually distinct from DIC. It is a hypercoagulable state, and major clinical finding in CAC is thrombosis, while in acute decompensated DIC, it is bleeding actually. So the clinical presentation of both the cases is actually 180-degree opposite. If we specifically target the pathophysiology of COVID-associated thrombosis, we'll see that initial infection by SARS-CoV-2 causes uncontrolled activation of lymphocytes, neutrophils, and increased release of cytokines and tissue factors. So this is the stage of cytokine release and tissue factor expression, which actually triggers and set the stage for thrombosis by either endothelial injury, hypercoagulability, or vascular stasis, the three prongs of vicious triad. This leads to activation of coagulation cascade and widespread thrombi formation. Another important stimulus for thrombosis in COVID patient is hypoxia. Lung is the major site of COVID infection, which in turn leads to hypoxia. This hypoxia causes trigger of hypoxia induction factor. This HIF activation on one hand leads to release of inflammatory cytokines, and on other hand it leads to release of integrins, especially tissue factor. Both of these leads to endotheliopathy, vascular inflammation, leading to widespread thrombosis. It is very important to differentiate sepsis-induced coagulopathy from DIC, as now what we are learning continuously from COVID patients is that sepsis-induced coagulopathy is a condition which is different from that of DIC. So ISTH has actually devised a clinical score for sepsis-induced coagulopathy that actually includes platelet count, PT-INR, and SOFA score. Any patient with a score of 4 or more is said to have sepsis-induced coagulopathy. On the other hand, if we see the DIC score, so DIC score has got platelet count, D dimers, APTT, and fibrinogen. And if we see the threshold for platelet is lower in DIC score, for PT prolongation is more in DIC score, and fibrinogen is also low. So that means that DICs actually represent a more severe spectrum of the same disease, but identification of sepsis-induced coagulopathy and DIC at relevant time point is very important. So how we can differentiate from CAC from DIC? So there are few discriminative feature which actually we can discriminate on the bedside as well, based on clinical presentation and lab results. Pulmonary involvement is more marked in COVID coagulopathy, and it is less marked in DIC. Bleeding is uncommon in DIC, in COVID coagulopathy, but it is prominent in DIC. If we see thrombosis is more marked in COVID coagulopathy, thrombocytopenia and PTT prolongation is less common. So that means patient of COVID coagulopathy will be having more thrombosis, less thrombocytopenia, and more pulmonary involvement. But the marker which we actually use at the bedside most frequently and which is most useful, I think, is fibrinogen levels and D dimers. So fibrinogen level and D dimers are markedly raised in patient with COVID-associated coagulopathy as compared to DIC, in which both fibrinogen and D dimers are, fibrinogen is reduced and D dimers is not that raised. If we see the incidence of thrombosis in COVID, so different studies have actually documented different frequencies, ranging from 15% to around 50%. Now the question rises that most of these COVID patients are either severe or critical patients. They are admitted to ICU. And we know that in ICU, the incidence of thrombosis is already high. So does it reflect a true picture that this thrombosis is actually triggered by COVID? So in order to differentiate that, if we compare it with historical comparator, that is those ICU patients who do not have COVID. So the frequency of VTE in non-COVID ICU patient is 16% as compared to as high as 60% in patients with COVID who are admitted to ICU. Over last 1 year, there is explosion of data on COVID. So similar is the case of COVID-associated coagulopathy. And we have got guidelines from ISTH, BGH, American Society of Haematology, Chinese guidelines, different review articles. So what to follow actually? Whatever we follow, the bottom line is that it is very important to identify COVID-associated coagulopathy at early stage and intervene early. Because if we do not intervene at that time, there will be progression to pre-DIC over DIC, and invariably these patients have multi-organ dysfunction, which is very difficult to control. If you see this diagram, COVID coagulopathy not only triggers thrombosis itself, but it actually triggers a number of other complications, ranging from thrombotic microangiopathy, DIC, hemophagocytic syndrome, and most interestingly, antiphospholipid antibodies. So we usually get calls regarding patients of COVID who have got thrombocytopenia, and we know that thrombocytopenia in this case is multifactorial and it is not because of this. So COVID itself, by triggering COVID-associated coagulopathy, can lead to all these spectrums. If you look at the site of thrombosis, so this is actually a very good French study, which was a retrospective analysis that actually documented around 40% incidence of thrombotic complications. And out of these, 79% are venous complications and 21% are arterial. And out of venous complications, majority were pulmonary embolism, DVT, or combination of both. And arterial thrombosis were either ischemic stroke, acute coronary syndrome, limb ischemias, or mesenteric ischemias. In contrast to thrombotic complications, the hemorrhagic events were less. They were 21%. And the hemorrhage actually virtually involved all the sites of the body. Now we know that COVID can trigger COVID-associated coagulopathy. It is a spectrum that is different from DIC. But why we are so much interested? It is because CAC has got its prognostic importance. And from the onset of COVID pandemic, data from initially China and then around the globe has documented that those patients who have got hematological abnormalities at admission actually fare poorly. So this was one of the initial studies that was published by Tang et al. And it actually documented that patients who had a higher APTT, higher D dimers, and higher FDPs at the time of admission actually behave poorly and were associated with high mortality. This was another study that was published in Lancet that actually documented the importance of D dimers. So those patients who had a D dimer, higher D dimer at presentation, they were actually associated with higher mortality. And if we see this curve, the difference between survivors and non-survivors among D dimers level is actually quite significant. Now, if COVID-associated coagulopathy has got this much of prognostic importance, it is very important to monitor these patients in order to intervene early. American Society of Haematology actually recommends monitoring of these patients with platelet count, PT, APTT, D-dimers, and fibrinogen. And now there is a lot of data to support that worsening of these parameters, specifically the D-dimers, indicate severity of COVID-19 infection. And improvement of these parameters along with stable or improving clinical condition provides confidence that stepping down of the therapy will be helpful. Now, we are repeatedly discussing the importance of D-dimers, but it is very important to consider that the method of doing D-dimers is very important. In majority of the labs across the country, we know that latex agglutination is used for D-dimer detection. We know which is less sensitive and less specific. So a more sensitive method like ELISA is actually the recommendation. Now, if we just have a recap of the things to remember about CAC. So coagulopathy is manifested as elevated fibrinogen, elevated D-dimers, and a minimal change in PT, APTT, and platelet count in early stages of infection. Increasing IL-6 levels are correlated with increasing fibrinogen levels. Now, this is very important. We know that IL-6 is used in patients with COVID as a prognostic as well as a therapeutic marker. So, anti-IL-6 tocilizumab is available, which is used. Then it is a marker for triggering of cytokine release syndrome. But IL-6 is not available across the board. So, fibrinogen is actually a surrogate marker of IL-6, which actually increases with IL-6 levels. Coagulopathy appears to be related to severity of illness and resultant thromboinflammation and not intrinsic viral activity. So the intrinsic viral activity does not associate with coagulopathy. That means there will be a lot of patients who will be PCR negative, but they will be having COVID-associated coagulopathy. Then elevated D-dimers and at admission is associated with increasing mortality. And then we know that rising D-dimer after admission precedes multi-organ dysfunction and overt DIC. So those patients who have got a rising D-dimers after admission, despite the therapy, these are the patients who require early intervention in order to prevent their progression to multi-organ dysfunction and DIC. Treatment recommendations have been proposed by a number of societies, starting from American Society of Haematology, WHO, ISTH, Chest Society, Surviving Sepsis Campaign. And we'll just have a brief review of the treatment of COVID-associated coagulopathy. So how to treat? So one thing is important. These patients will be having coagulation abnormalities, but they will not bleed. So do not treat the labs. Blood component should be reserved for active bleeding, invasive procedure, and high risk for bleeding complication. What we saw in first wave of COVID, that these patients who were having prolonged PT, APTT, thrombocytopenia, they were given blood products injudiciously. As a result, a condition which is already prothrombotic, and we are adding to prothrombotic state by giving them more blood components. So that is actually detrimental. So components should be reserved for active bleeding or invasive procedure. The choice of anticoagulation. In acutely ill hospitalized patients with COVID-19, low molecular weight heparin or fondaparinux is preferred over unfractionated heparin. And low molecular weight heparin, fondaparinux or unfractionated heparin is actually preferable over DOACs. The rationale of preferring low molecular weight heparin over unfractionated heparin is from different clinical trials which were carried out in non-COVID patients. And the main of them were PRINCE trial, PRIME trial, Hillbaum and Prevail trial. We know that these were the trials which actually laid the foundation of using low molecular weight heparin over unfractionated, despite the concerns that the antidote of low molecular weight heparin is not available. It has got a prolonged duration of action, but there was a significant mortality benefit and relative risk reduction of thrombotic episode and hemorrhagic episodes, resulting in approval of low molecular weight heparin. Another thing which is used very commonly even in Pakistan as well in COVID patient is the use of antiplatelets. So there is generally a cocktail of treatment which is advised by most of the physicians that if you are diagnosed with COVID, you start this, and antiplatelet is one of them. So all the guidelines, American Chest Guideline, American Society of Haematology, Surviving Sepsis, they actually recommend against the use of antiplatelet agents for venous thromboembolism prevention. The main reasons for that are two. Number one, if we have seen the retrospective data, the thrombotic complications are lesser as compared to venous thromboembolism. So arterial thrombosis is less. And we know that antiplatelets have their main action in preventing arterial thrombosis. Moreover, the risk of bleeding actually increases proportionately in patients who use combination of both. So antiplatelets are not recommended. And what is the duration of thromboprophylaxis? American Chest Society recommend only inpatient thromboprophylaxis, and they recommend against extended thromboprophylaxis after hospital discharge. One exception is the guidelines from ISTH, which we'll just have a review in a short period of time, which recommend 2 to 4 weeks of extended thromboprophylaxis after discharge. Another thing which we have actually seen clinically as well, and which we get calls as well, that the patient is on therapeutic dose anticoagulation and they have another episode of VTE. So what to do in these cases? So those patients who have got a recurrent VTE despite anticoagulation with therapeutic weight-adjusted low molecular weight heparin, it is suggested to increase the dose of low molecular weight heparin by 25 to 30%. And if the patient is on vitamin K antagonist or DOACs and they have got a recurrent VTE, it is recommended to switch them to therapeutic weight-adjusted low molecular weight heparin. So those patients on heparin who have a new episode, increase the dose. Those patients who are on vitamin K antagonist or on DOACs, switch to low molecular weight heparin. So if we summarize these guidelines, anticoagulant prophylaxis with low molecular weight heparin or unfractionated and no antiplatelet. And out of the choice, low molecular weight heparin is preferred. Standard dose anticoagulant prophylaxis only, do not use therapeutic dose. Inpatient thromboprophylaxis only, after discharge, do not give thromboprophylaxis. No routine screening for detection of asymptomatic VTE. And another important point is regarding thrombolysis. Thrombolysis is indicated in the spectrum of COVID is if the patient has got acute PE and cardiopulmonary deterioration after initiation of anticoagulant. At outset, thrombolysis is not indicated as in the case of non-COVID patients for hemodynamic compromise, but if the patient has got a new onset thrombosis. So another area of controversy and which is developing is that those patients who are admitted with critical COVID, whether they should be given prophylactic anticoagulation or therapeutic dose anticoagulation. So the latest recommendation is that therapeutic anticoagulation is not required unless other indication for therapeutic anticoagulation is present. For example, patient was already on therapeutic dose anticoagulation because of atrial fibrillation, recent venous thromboembolism, massive pulmonary embolism, otherwise use prophylactic dose. So there were 3 actually randomized trials that were trying to answer this question, prophylactic versus therapeutic. They were REMAP CAP trial, ATT-ACC trial and ACT4 trial, and all of them actually stopped enrollment on 21st December 2020 because of interim results and data analysis which actually recommended against the use of therapeutic dose. And as discussed, in patients who are already on anticoagulation for VTE or AF, therapeutic doses should continue. And then how to use thromboprophylaxis? Thromboprophylaxis with low molecular weight heparin is recommended for all hospitalized patients in the absence of bleeding and held only if the platelet count are less than 20 to 30 and fibrinogen is less than 0.5. These thresholds are lower as compared to the thresholds which we use generally, that we normally withhold anticoagulation if the platelet count is less than 50 or reduce their dose. But in case of COVID, because sepsis-induced coagulopathy or COVID-associated coagulopathy is a frankly prothrombotic condition, the thresholds are lower. And abnormal PT-APTT is not a contraindication for pharmacological thromboprophylaxis, and it is not a contraindication to withhold anticoagulation. And mechanical thromboprophylaxis by IVC filter should be used only when pharmacological thromboprophylaxis is contraindicated. If we see, these are the 3 most well-reputed and frequently quoted guidelines regarding use of thromboprophylaxis in COVID thrombosis. ISTH is ASH and chest guidelines. If we see that the major difference in these guidelines is, if we see the last row, this is the extended anticoagulation. So extended anticoagulation is recommended by ISTH. ASH actually does not give answer to that question, and chest guidelines do not advise. Rest are the recommendations which I have previously discussed. They are actually the same in 3 guidelines. Another interesting and evolving scenario is the use of nefamostat. So nefamostat is actually a serine protease inhibitor. It strongly inhibits proteolytic enzymes such as thrombin, plasmin, and trypsin. So those enzymes which are involved in CAC, they are inhibited by nefamostat. It has been used in Japan for over 30 years now to treat DIC and pancreatitis. It does not have FDA approval, but it is frequently used in Japan. It has a strong anti-fibrinolytic activity and a weak anticoagulant effect. And the studies are now, especially in Japan, they are actually evaluating the role of heparin combined with nefamostat. That is anticoagulation with one drug and anti-fibrinolytic activity with another drug to overcome this weakness, and we are awaiting the results. Definitely they are trials as all the other trials in COVID. Another trials which are done are the use of fibrinolytic therapy, including inhalational therapy. Treatment by inhalation of fibrinolytic substances such as TP and plasminogen has been used. Inhalation of fibrinolytic agent actually lead to fibrinolysis and dissolve fibrin containing exudates, which we have seen are the major trigger for CAC. The fibrin formed in lung parenchyma may be expected to dissolve. Again, the trials are in progress and the results are awaited. Now I'll just likely to briefly discuss the recommendations during pregnancy and lactation. If antithrombotic therapy is prescribed during pregnancy prior to diagnosis of COVID, this therapy should be continued. So we know that warfarin is not used in pregnancy. So all the anticoagulations which are otherwise used in pregnancy, and if the patient is using already before COVID, it should be continued. For pregnant patients who are hospitalized for severe COVID-19, prophylactic dose anticoagulation is recommended if there are no contraindications. And anticoagulant therapy used during labor and delivery should be the same as that is used in non-COVID patient. So if we just have a brief overlook, the guidelines for treating COVID with thrombosis in pregnancy is the same as in non-pregnant women and in all the patients who do not have actually COVID. So I'll just like to at the end briefly share our data. So this is data from our center, which is actually Pakistan's largest center in which COVID is actually treated under one roof. So it is the largest hospital, which is the tertiary care hospital. If we actually analyzed moderate, severe and critical COVID patients who were admitted, and the initial data analysis was done for 549 patients. If we see this data, we'll see that patients who were non-survivors, who were dead, they actually had a higher WBC count, which was statistically significant, higher ANC and higher NLR, which is actually in the same lines as the data from all over the globe. This article has been submitted for publication and has been accepted and will be published soon. So I would just like to share the coagulation abnormalities also, which we encountered in our patient. Patients who were non-survivor, they had a significantly low platelet count as compared to survivors. They had a prolonged PT. There was a trend toward prolongation, but the difference was not statistically significant. But APTT prolongation was statistically significant. The D dimers, if we see, they are statistically significant in our data as well. Plasma fibrinogens were not. So out of coagulation abnormalities, thrombocytopenia, APTT, and D dimers among non-survivors were significantly associated with outcome in our data. If we see the effect of D dimers on overall survival, those patients who had got a D dimers level of more than 400, as indicated by the green line, they had a significantly inferior overall survival of 59.5% as compared to those who had a lower D dimers. So higher the D dimers, inferior is the survival in our study. I'll conclude by saying that hypercoagulability is a prominent feature of COVID-19 infection, especially in severely affected cases. All hospitalized patients should receive thromboprophylaxis. D dimers correlate with outcome. A high index of suspicion is required for diagnosis and management of COVID-associated coagulopathy. Thank you very much.
Thank you, Dr. Raheel, for giving us such a comprehensive talk on COVID-associated coagulopathy. Now coming to our last speaker, Dr. Abdul Mannan from UK. He is a graduate of Bahauddin Zikriya University, and he completed his first fellowship from College of Physicians and Surgeons of Pakistan and second fellowship from Royal College of Pathologists UK in Haematology. He is working as consultant hematologist and director Haemophilia Centre, North Wales Cancer Centre. He will be delivering a talk on hemophilia with inhibitors, therapeutic advances.
Bismillahirrahmanirrahim, and thank you to all the organizers for giving me this opportunity. And I'm really thankful to my teachers who taught me at Children's Hospital and Shaukat Khan Memorial Cancer Hospital, and they made me capable of crossing this difficult road that finally led to a beautiful destination where I'm currently working in North Wales as director of the Haemophilia Centre. My today's talk is related to hemophilia, the therapeutic advances. I initially thought of giving it a more detailed talk involving the immune tolerance induction, but then due to the time constraints, I think I will focus, after a brief introduction of hemophilia and inhibitors, I will focus myself towards the therapeutic advances in the field of hemophilia. I will touch a little bit related to gene therapy, although up till now, no gene therapy trial has included the patients with inhibitors on hemophilia. My main focus will be the patients of hemophilia A. So before starting, I would like to thank Professor Peter Collins and Dr. Pratma Chaudhary, Peter Collins for providing some of the slides for this presentation. Allah has given us a beautiful hemostasis system. Actually, I will say that it is very balanced sort of a hemostasis, which is between the procoagulant and anticoagulant coagulation factor. And if we just look at a minor disruption in this, suppose like the factor 8 is knocked down, then we can see that this can lead to a major disease or major morbidity, which is leading to bleeding. So hemophilia A basically is an X-linked bleeding disorder caused by deficiency of coagulation factor 8 due to mutations in the coagulation factor. Hemophilia usually affects almost all areas of the world, and almost 1 to 1,000 to 10,000 newborns, they are involved worldwide. And the most common sites of the bleeding are the joints, muscles, and soft tissue hematomas. The main determinant of the bleeding phenotype is the level of the factor 8. And based on this, we can subdivide this disease into the severe form with less than 1% factor 8 activity, and then moderate ones, which usually have an factor activity of 1 to 5%. And then the severe ones, where activity is usually remains between 5% to the 40%. The treatment of hemophilia, whether it is the on-demand or the regular prophylaxis, it is mainly around plasma-derived or recombinant coagulation factor, and also the extended half-life. So main treatment source we have is the coagulation factor currently. Inhibitor, they develop in hemophilia A, most commonly in the severe hemophilia, but the mild or the moderate forms, they do have the ability to develop inhibitors as well. And it is the main treatment-related complication in patients with severe hemophilia. Almost 95% of the patients with hemophilia A who develop inhibitors, the inhibitors usually occur during the early phase of their life, maybe around 20 to 75 exposure days. How to define an inhibitor? When we start detecting an inhibitor titer through the Bethesda, and the inhibitor titer is above 0.6 Bethesda unit, then we, on at least 2 consecutive plasma measurements, then we classify that the patient is having a inhibitor which is detected. So further, based on the inhibitor titer, they are grouped into 2 major groups, which is the high titer inhibitors having a titer of more than 5 Bethesda units, and then the low titer inhibitors, which are basically having the active Bethesda unit less than 5 Bethesda unit. How frequent they are in severe hemophilia, almost 3 out of every 10 people, so around 30% of them, they develop this treatment-related complication. And I will just briefly touch the immunology, as we know that we have a natural tendency that we don't recognize our self-antigens. And these cells which recognize the self-antigen, they basically lead to an apoptotic death. But like the surviving cells are those which basically cannot detect. But as a result of some genetic mutations, like some of these hemophilia A are unable to express large portions or any amount of the factor A. And these patients are not able to eliminate a high affinity factor VIII reactive T cells. So what happens is that when their T cells, they are exposed or get in contact with the dendritic cells, which have basically churned up or crushed the factor VIII, and that lead to basically their further differentiation. And some of the cytokines, they can lead to a type of T cells, which basically, once they get in contact with the follicular B cells, which already have their factor VIII exposed through the B cell receptor, they stimulate them, and finally, they can turn them into the memory B lymphocytes and the plasma cells. And on repeated exposures, we start seeing the surge in the inhibitors. Usually the bypassing agents, or which are either the activated PCC or the recombinant factor VII, they are the main treatment modalities for the patients with who develop inhibitors, because giving them the factor VIII is usually leading to the rise in the inhibitor titer. Immune tolerance induction is the unique available treatment for eradication of inhibitor, and it shows a success of around 60 to 80% in treated patients with hemophilia A. However, ITI is a demanding and a very high cost treatment that requires a frequent infusions of the factor VIII, and which I'm currently not discussing and going into the detail. Otherwise, my whole presentation will end up discussing the immune tolerance and the trials related to immune tolerance. We'll move to back to our first slide, in which I showed you that there is a nice balance that Allah has created for us by providing us the coagulation factors, and there are which are procoagulant, and when our body requires, they start then generate the cascade of the coagulation. And in order to counter overcoagulation, we have a battery of factors which basically help us to limit the coagulation. So whenever there is a disruption in this, like it leads to the bleeding or clotting. So first thing is among the transformational therapies, and that is basically in boom today are the mimetics, which is basically a treatment that resembles the intrinsic factor 8 inside, which is the emicizumab. Emicizumab is given subcutaneously, and it is miraculous, I will say, because patients with hemophilia A, it is finding a vein or like venous access is a major issue with the passage of time. So giving a drug subcutaneously once weekly or sometimes every 2 weeks, or now even like every 4 weeks is really a miraculous achievement. And as we know that our intrinsic factor 8 in normal people, that basically links the activated factor 9 with the factor 10, and like leads to the common pathway activation. This mimetic emicizumab basically binds these factor 9 and the factor 10, and then like triggers the effects similarly in a similar fashion like the factor 8. No one can challenge Allah subhanahu wa ta'ala, and but like what a beauty in this factor 8 is that if we just go and deeply study the factor 8, like we see that like there are multiple sites of interaction with these two coagulation proteins like factor 10 and factor 9A. Although like the science has approached, but like we finally reached after a lot of research with a single attachment site. So this affinity for the enzyme and the substrate in case of a natural factor, it is very high, although like it is very low in case of emicizumab, but it is exploited in such a way that like it is more than enough or sufficient to produce a blood clot. And usually the normal factor 8, it is quite specific for factor 9 activated and factor 10 inactivated. And it does not bind to activated factor 10 or inactivated factor 9. But if emicizumab, there is no distinction. Like it picks up everything, which is whether active or inactive 9 or active or inactive 10. The cofactor activity, similarly, of emicizumab in order to bridge these two is quite partial. And I will say that like the antibody is quite in excess over the enzyme and the substrate, but like here in case of normal, it is quite balanced. So the level of regulation even like is on the lower side, but still like we are exploiting it to make a good clot through the emicizumab. The 4 major trials in the HAEMCON and then like one non-interventional study. And during this study, like most of the patients, like they were switched from this study right into these trials, and we will be discussing them later. The first trial, which is published in 2017 in NEJM, was the HAEMCON-1 trial. It was a landmark trial that actually revolutionized the treatment for the hemophilia A patients, and with even like the patients with the high titer inhibitors. And so in this trial, basically it is the multi-center phase 3 trial, and the primary endpoint was the difference in the bleeding rate over the last at least 24 weeks of treatment with or without emicizumab prophylaxis. So in the first 2 arms, the emicizumab prophylaxis was like 1.5 milligrams Q weekly, and there was no emicizumab prophylaxis group. And then like those patients who were on like previously the prophylactic, and they were moved onto the third group, which is 1.5 milligram Q weekly, and emicizumab prophylaxis. So mainly like it is the comparison which they are comparing are those ones which were getting an episodic sort of the treatment for the patient with an inhibitor whenever there is a bleed, or like those who were on some regular prophylaxis and they were switched on to this. And then like almost 7 patients, like they moved from the NIS study to include into it. So the primary outcome, it showed that patients on emicizumab prophylaxis, there is an 87% reduction in the annualized bleeding rates. And patients in the emicizumab, like with the zero treated grade, they were around 62%, and those with the zero treated grades, they were only 5.6% in those patients who were not on the prophylaxis group. And the intra-patient comparison of annualized bleeding rate for those patients who were on bypassing agents and their patients with the zero bleed, they are like around 12.5%, and those patients from the HAEMCON, they have like bleeding reduction in the bleeding annualized bleeding rate of around 70%. So then we move to the HAEMCON2 trial with the emicizumab prophylaxis in patients less than 12 years. It is mainly involving the pediatric age group, and with the factor A, hemophilia A, with the factor VIII inhibitors on prophylaxis. And the emicizumab dose, which is pegged in the interim arm, was the 3 milligram per kg for 4 weeks, and then like after this loading dose, the patients, they moved to 1.5 milligrams per kg. And then like the emicizumab, 2 other doses were trialed here, and in almost 20 patients, they received 3 milligrams per kg every 2 weeks for 52 weeks, and then like 6 milligrams per kg every 4 weeks for 52 weeks. And the primary endpoint was the number of bleeds at the end of the year. So the patients basically in the 3 milligrams per kg body weight initially who got the loading dose, and then like they moved to the 1.5 milligram weekly. Like we can see that like the patients with the zero treated grade, they were around 76%, and in total 22 treated bleeds were reported in 15 of 65 participants in less than 12 years of age, and 91% of the patients who require like of the treated bleeds, they were basically the traumatic, so spontaneous bleed, they were like drastically reduced. And so the bleeding rate between the Q2 weekly and Q4 weekly, you can see that like the patients in the Q2 weekly, the zero treated with the zero treated rate, like around 90% and then like Q4 weekly, basically there is like 2 patients actually who actually like one participant who had 6 target joint bleeds in 24 weeks before the study entry had another 3 joint bleeds. That is the one patient which actually led to this 6-figure of 60-figure, and one participant who has develops the drug-associated emicizumab-associated neutralizing potential antibodies that has so these 2 patients, basically these 2 participants, like they have the higher annualized bleeding rate among this group. That is why like it is around 60%. So in phase 3 emicizumab prophylaxis trial in patients above the age of 12 years with hemophilia A, that is without inhibitors, and in which the patients who were not having the inhibitors, they were included into it is a randomized phase 3 trial with the primary endpoint of the differences in the bleeding rate. And it includes also the patients with NIS study and non-NIS study. And emicizumab Q weekly 1.5 milligrams versus the emicizumab Q2 weekly 3 milligrams versus no prophylaxis. And then like from the previous factor VIII prophylaxis group, they were around 63 patients. That is, they also received the same 1.5 milligram per kilogram Q weekly. So basically there are 4 groups. In the first group, in the first 3 groups, they have received previous episodic treatment, and like the 4th group, basically there was previous factor VIII prophylaxis. So they had a nice comparison between the 2 dosages of those who are on episodic versus no prophylaxis, and those like who were initially taking a factor VIII regular prophylaxis and then moved to the emicizumab. And you can clearly see that like those patients who were on having the no prophylaxis, their annualized bleeding rate versus those patients who have got 1 point reduced to those who got 1.5 milligram versus 3 milligram, there is a drastic reduction in the annualized bleeding rate. So, treated bleeds in patients previously receiving prophylaxis, there is a drastic reduction in that as well. In that, once they were moved from their regular routine prophylaxis to the patients who to the emicizumab 1.5 milligrams per kg weekly. The fourth trial of HAEMCON, basically it included, it is a multi-center, non-randomized phase 3 study, and it is basically 7 patients. They initially run for the few months, and this was basically to run the pharmacokinetic data and to gain information regarding 6 milligrams Q4 weekly dose. And then the first phase of started, which is with the loading dose, and then 3 milligram per kg Q weekly for 4 weeks, and then like emicizumab dose, which is maintenance dose, was 6 milligram per kg. Main aims were the emicizumab pharmacokinetic and safety, bleeding rate, and pharmacodynamic markers were studied. And in the initial one, then like the expansion phase, they have bleeding rates, safety, and pharmacokinetics and quality of life data was analyzed. So annualized bleeding rate of treated bleeds like was around only 2.4%, 23 or 41 reported no treated bleeds, in 37 only 0 to 3 treated bleeds. And in all the, if I summarize, in all the 4 HAEMCON trials, there is a consistent level of emicizumab that is maintained, but it usually requires 1 to 4 weeks. That is the aim behind this loading dose phenomena. And then like emicizumab consistently keeps its level at a steady level in all the 4 trials. So this is the brief summary of all the participants, like in the 4 trials, and they are quite nicely balanced in among all the trials, and with the patients with inhibitors and non-inhibitors. Similarly, like in all the 4 trials, this is the week-wise cutoff for the annualized bleeding rate, and then we can see that like as the patients they have a longer sit in the trial, like the bleeding rate actually gradually drops down, and similarly you can see the proportion of participants like from the 0 to 0 to that is also remained consistent over the passage of time. The mean annualized bleeding over the time by all the studies, that is also showing that like emicizumab is doing remarkable and an excellent work over here. So emicizumab is indicated now for the routine prophylaxis to prevent or reduce the frequency of bleeding episodes in adult and pediatric patient ages, newborns, and older patients with hemophilia with or without factor VIII inhibitors. 3 thrombotic microangiopathy and 2 VT is reported, and the prophylactic emicizumab regime, and all the thromboembolic like occur during the supplemental treatment with APCC for the breakthrough bleeds. The impact of emicizumab on the monitoring assays, this is a very important point to discuss here. If we just consider like the difference in the emicizumab factor VIII versus the emicizumab and the interaction with the factor Xa, then like we can easily understand that. Once basically like when we do a APTT, I will briefly discuss here that in a patient with hemophilia, then like the APTT basically relies on the bypass loop, and that emicizumab doesn't rely on the bypass loop. It goes and as I mentioned that it picks whatever available, like factor 9 active, inactive, factor 10 active, inactive, unites them and makes a big clot. So that is the reason that like when the patients they give, so usually the APTT becomes normal. Similarly, the presence of emicizumab lead to overestimation of the factor VIII activity in 1 stage factor VIII assay, and we see that like 100% of the factor VIII activity with just like 10 microgram later of the, so it is absolutely not a recommended way to proceed for the factor VIII activity in patients on emicizumab. So emicizumab basically the bovine derived factor, they are not sensitive to emicizumab but sensitive to factor VIII. So this is usually a recommended method by which you can get the intrinsic factor VIII activity. So it is by using the bovine derived factors through the chromogenic assays. Similarly, usually like emicizumab has no interference observed with immunoassays, ELISA or latex-based or chromogenic assays involving D-dimer, factor 13, antithrombin activity, protein C, S, one-way band activity, antigen, plasminogen, and plasminogen antigens. The evaluation of assays, which are basically the patients on emicizumab, there is no interference observed in one stage. Single coagulation factor, say, triggered by the prothrombin activator or thrombin time. So these are the thrombin time and protein C and clause fibrinogen. Weak but detectable effect on INR and on PT and FPT-derived fibrinogen assays is detectable in the patients who are on emicizumab. Evaluation, so like strong assays strongly affected by emicizumab. These are basically all the APTT-based assays, and I have previously explained you the reason. And these are the protein C activity, protein S activity, and activated protein C ratio. So these assays basically are APTT dependent, and they are adversely affected by the presence of emicizumab. Surgical management, the experience that we learned from all the HAEMCON trials, I will try to explain this. And so all the patients during these HAEMCON trials, major and minor surgeries were performed. Major surgery, they listed as like the opening of body cavity, mesenchymal barrier, or an organ. And the minor studies were like the mucous membrane related issues, skin, or some superficial subcutaneous tissue related issues. So the median duration of emicizumab, almost in HAEMCON1 was like 101 weeks, and the rest of the trials there. So they are mostly like more than around 68 to 70 weeks. And total of 126 patients who received emicizumab underwent at least one surgical procedure. And so the 233 surgeries in HAEMCON1 to 4, 18 patients had major, and 215, these are the cut down breaks for the surgeries. And most of the minor procedures were managed without prophylactic coagulation factor and were not associated with post-operative bleed. Of the 144 minor procedures managed without prophylactic coagulation factor, 128 did not result in the treated post-operative bleeds. Among the dental procedures, 64 dental surgeries and 9 procedures managed out of the 42 without prophylaxis and had a treated post-op bleed, and 5 procedures out of the remaining 22 procedures managed without prophylaxis and had a post-operative bleed. So antifibrinolytic agents were definitely used in around 43 dental procedures in 28 participants. The central venous devices related procedures, 1 out of the 25 procedures managed without a prophylaxis and had a treated post-op bleed, and 2 out of the 9 procedures managed with prophylaxis and had a treated post-op bleed. So, and also anti-prophylaxis have been used. So out of the 34 venous surgery, the majority of procedures were managed without prophylaxis and were not associated with bleeds. And similarly, among the major surgeries, 18 of the major surgical procedures, the majority were managed with prophylactic coagulation factor and did not result in the post-operative bleed. So in the HAEMCON, like in the Stacy trial, which I personally participated as well, is the special guidance were given to us, for those patients who are on the Stacy trial, that the bypassing agent that we can use, it should be by the discretion of the trial team and medically supervised. And they allowed us to use the recombinant factor 7A because this study was related to the patient with inhibitor. And at that time, it was a hot burning question of the thrombotic microangiopathy. So APCC was quite discouraged, and one of our patients has to go out of the trial because accidentally, APCC has been given by an ED doctor when the patient came with some issue that actually resulted in minor operation, and then the physician has prescribed APCC to him. British guidelines by the Peter Collins that for the treatment of bleeding for the minor surgery and consider use of tranexamic acid without additional hemostatic effect, and close clinical reviewing is required, and factor recombinant for the management of surgical bleeding if necessary, or single dose of recombinant factor 7A, usually 45 to 90, with the further treatment required. For the major orthopedic surgery, usually require additional hemostatic therapy and approach, but it does not, definitely there is always the risk of bleeding. And in patients receiving emicizumab, clinical hemostasis is usually unpredictable, and the data is quite limited, and considered deferring non-urgent major surgery until more data is available. And all the treatment with emicizumab, recombinant and factor 7 APC factor rate must be recorded in the heme track, which we use for our patients' record in UK by the UK HCBO. These safety events in HAEMCON 1 to 4, long-term emicizumab prophylaxis, no deaths, and thrombotic embolisms of thrombotic microangiopathy beyond those in the HAEMCON 1. 103 patients had severe side effects reported in 75. The most major effect are the infusion site-related events and the drug-related antibodies. They are like less than 1% potential. Then we go to the next topic, which is the rebalancing hemostasis. If we just see the extrinsic and intrinsic pathway, there are two targets. One is the tissue factor pathway inhibitor. If we knock it down, then we assume that like maybe the extrinsic pathway will get an edge and make a good amount of thrombin. Similarly, like the antithrombin is the second target, and the fitusiran we are going to discuss now to exploit this and to keep this balance. This fitusiran is the RNA interference therapy, and it specifically targets antithrombin messenger RNA in the liver and suppresses the production of antithrombin. It is chemically synthesized and targeting ligand to deliver to the liver and the site of antithrombin synthesis, administered subcutaneously once monthly and cause a reduction in the antithrombin levels. So what we expect, like the mean antithrombin activity, that is like when we see that days since the first dose and the participants of hemophilia on 1 monthly regime. This is the phase 1 fitusiran trial, antithrombin lowering after the dosing in the patient with hemophilia A and B. Different levels of the doses were used, and mean antithrombin activity relative to the baseline, we can see that like how it has reduced based on the dose, the antithrombin activity. And similarly, the lowering the antithrombin activity to more than 75% has produced an enormous impact, like in case of generation of the peak thrombin in comparison with the healthy volunteer group. And similarly, like the bleeding events, we'll see that like less than 25% versus the more than 75% lowering, there is a difference in the annualized bleeding estimates for after this phase 1 study results. So phase 2 study has been done, and like it is the dose escalation phase 1 trial of designed that basically the patients with the moderate to severe hemophilia A or B, they were given like into 2, and those patients with the inhibitor, they were showed here like in the green part with the fitusiran of 50 to 80 milligrams, and then we'll move further. Like there is a duration of dosing is like around median duration is 2.6 years, and we can see that the mean antithrombin activity after the initial phase, it has consistently remained low since the month after the first start, and then we can say that like the mean thrombin generation is basically increased as compared and reaching the area of almost the healthy volunteers. So we can compare that on the patients who were on prophylaxis on demand. There is a reduction in the patients without inhibitors who are on prophylaxis, or there is a reduction in the bleeding rates, definitely, and patients with inhibitor also, like we can see that like there is a reduction in the bleeding, annualized bleeding rate. So 4 serious events, they had adverse events, they occurred, and 1 arterial thrombosis, 1 patient had seizures and is elevated in the ALT and AST, and a fatal cerebral vein thrombosis. October 2020 study was on hold, I think because of these adverse serious events. And phase 3 trials, currently they are enrolling regarding this now. And then the other one is the monoclonal humanized anti-tissue factor pathway inhibitor antibody, which is the trial, like it is the multi-center double-blind randomized trial, first human phase 1 dose escalation trial. It is in the healthy male volunteers They challenge with the two doses between the 0.5 to 250 micrograms IV versus 50 to 1000 micrograms subcutaneously. And the male participants with severe hemophilia A between ages of 18 to 65 years, and they were challenged and compared in these two groups. Primary endpoint was the severity and no serious adverse event antibodies to and no antibodies to coincide. And we can see that the higher the dose over here, and the mean concentration concentration after the IV administration, basically in patient healthy volunteers and in the patients with hemophilia A, and we can see that like it has attained a quite decent and nice level after the injection. The dose-dependent decrease in the free tissue factor pathway in a better, and dose-dependent increase in the D dimers we can see, which is and the prothrombin fragment 1 and 2, which is saying that like thrombin, which is indicating thrombin generation, and 24 total bleeds or bruises reported in 14 patients with the hemophilia, no bleeds at high concizumab, and low tissue factor concentration except a bleed called a minor finger cut. Patients may have been treated with factor 8. So the phase 2 trials, they are in process, and assessing the efficacy of concizumab subcutaneously implementing bleeds. And March, the one study is in patients with hemophilia A and with inhibitors, randomized 2:1 to concizumab versus on-demand treatment, significant more than 75% reduction in annualized bleeding rate in patients receiving concizumab. Study in patients with severe hemophilia A without inhibitors, a single-arm study, all patients treated with low annualized bleeding rate. Study March 2020 study was put on hold due to the 3 non-fatal thrombotic events, and August 2020 it was planned to be reopened, but actually because of this COVID, I think like it is still on hold in at least in UK. Now we'll go for our holy grail, which is the gene therapy. I will briefly touch in my few slides, which is the goal for the continuous production of the factor 8 or 9 with a single administration of the vector gene, and alleviates the need of the repeated prophylactic treatment. Numerous trials have been initiated on it, and few briefly by the first, which is the Valoctocogene trial through the adenovirus 5. I will just discuss briefly about it. And it is a multi-center trial, adult males over 18 with severe hemophilia A, and 15 received a single dose of the virus, which is they basically 7 have received the 6 times 10 to the power 13 and viral genome per kg, and like 6 treated at the dose of 4 times 13 genome, and 2 received low doses. So primary endpoint for safety, dose needed to achieve factor 8 activity of more than 5 at 16 weeks, and secondary endpoints for the exogenous use of the factor 8 and the bleeding episodes. And we can see that in the green one, the 6 times 10 to the power 13 group, we can see that the factor 8 activity is ranging like around between in some cases like around 30 to between 20 to 30% also. And as with the passage of time, they are making a reasonable. And in cases of the 4 into 10 raised power 3, with the passage of initially, they took some time to mount a reasonable level, but and consistently maintain a decent level above 5% for the factor 8. So holding up nicely the factor the intrinsic factor 8 by the addition of the gene to the vector. Okay, so in the high dose cohort, there is a 95% reduction in the cumulative mean for the annual bleeding rate, and also like there is a 93 in the low dose cohort as well. Similarly, the sustained reduction in the annualized factor 8 with the both dosing cohort that is seen here. And so I will just finish it by saying that multiple new therapies are currently being developed for the patients with hemophilia A with or without inhibitor. Each is designed to address the gaps and challenges in the current treatment. The non-factor therapies have unique targets, offer steady state protection against the bleed, and are unaffected by inhibitors. Adverse events in patients choosing concomitant large doses of factor therapy are concerning, and especially bypassing agents. Gene therapy offers a potential for cure or near future, but completion of the clinical trials still are a few years away. Thank you very much.
This session is open for question and answer session and panel discussion. Due to restriction of time, we can have only one question. Thank you.
Well, thank you really. I joined on this Zoom network. It was very productive session really.
So,
particularly yes, just really one comment, very brief comment on this Raheel's presentation. Well, it was a great problem in our country really, particularly the COVID patients. And APTT was prolonged and physicians were adamant really all the time that we must infuse blood and blood product because APTT is prolonged. The job of hematologists is really to teach them APTT prolongation is not always due to factor deficiency. This is very important really. Unnecessarily, as he said in Raheel said, unnecessarily huge amounts of blood and blood products were transfused in these patients and they were not bleeding and it was counterproductive really as well. One of the really phenomenon noticed in COVID patient is high titer of antiphospholipid antibodies really. Actually, it's a historic mistake. This lupus anticoagulant doesn't mean that it is anticoagulant, it is procoagulant. It is misnormal. So these antiphospholipid antibodies and lupus anticoagulant, I think, well, I am monitoring a study really in which they are testing them for lupus anticoagulant presence and anti-gyrolapin antibodies and really very high incidence, reasonably very high incidence. So Raheel, I think you must educate them that APTT prolongation is not always due to factor deficiency. There are other causes and APTT prolongation might really indicate a thermophilic state. Thank you very much.
So
thank you. Oh, sorry.
Thank you very much, sir.
Thank you, General Ayyub. I'm Tahira Zafar and I'm the Hemophilia Center Director.
I'm seeing you. Yeah, I'm seeing you.
In Rawalpindi. I'm talking to, I know Ayyub, you know me, but I'm talking to a lot of other people who don't know me. So, very interesting session. And with my background, I was more interested in listening to more things about bleeding. And we did have 2 papers. And I just wanted to ask a question to Dr. Abdul Mannan because fortunately we have recently started using emicizumab at our center, which has been donated by the World Federation of Hemophilia in their humanitarian aid program. And we are about like 6 weeks from using it and very well tolerated by our patients. And we have not had any breakthrough bleeds during these 6 weeks. And we are using it in 3 categories: under 12s with inhibitors, under 12s without inhibitors, and over 12 with severe bleeding, who have had severe bleeding episodes in the past, or ABRs of more than 8 or so. So my question really is that emicizumab, as we know, is used in prophylaxis. I just want to know why, if it can be used in prophylaxis, why can't we use it in bleeding?
The issue, as I have previously, can you So the issue that I highlighted in my presentation is basically the mechanism through which the emicizumab works. The emicizumab, working of emicizumab is not as strong as the intrinsic factor 8, which is basically naturally produced. Okay, so based on its mechanism of action, we don't know whether the acute surgical or acute need basically will be extrapolated into a sufficient formation of the clot. That is why basically we prefer to use it along with, in case of an insult or a surgery or something, we use the emicizumab. We don't stop it. We use it along with the routine factor VIII which the patient was using, or the patient with the inhibitors, we give additionally to support. And usually 1 or 2 doses are required and not more than that. And once we think that like the patient is clinically stable, we just carry on using the emicizumab prophylaxis, and not these patients usually don't require it. So we use it concomitant use of this just to facilitate, because the data available regarding is very limited, particularly for the minor patients. You no need to use any sort of the factor VIII. Just minor procedure can be taken care by the prophylaxis through the tranexamic acid antifibrinolytic. For the moderate to severe bleeding risk procedure like opening a cavity or major surgery, in order to cover that surgery time frame, the routine factor is usually recommended, or those patients who were on some bypassing agent, so preferably factor VII to avoid thromboangiopathic complications, and then like to continue with the
Thank you very much. I think this is very useful, because I observed that you were using no factors during minor procedures, so this will be very useful and will limit our utilization of factor concentrate.
Basically, Dr. Tahira, the amount of trust that we have in, I think that since times, like long time, we are using, and we started trusting the factors. It is the hematologist's appetite as well, like when they are sending their dear patients like to some surgical threat or something, they just want to keep them safe. So this is also a factor which is, I will say that, consider it as a bias of using the overdosed amount, or like the extra use of the factor VIII or the bypassing agent in patients who are on emicizumab. So for like the bleeding risk patients, like for the severe bleeding risk procedure, I will recommend definitely concomitant use of factor VIII, because of the limited data available right now. But as the data will mature, and then because still like in UK, whole UK, the patients, they are still on the factor VIII, and we are going towards a slow transition towards the emicizumab. And in my center, we have only 3 patients up till now, and like gradually we are escalating them, and to our all severe hemophilics patients, at least like towards the Hemlibra, and that's like we'll see how the time will teach us about it.
Right, very good, thank you. Right, about this is again my sort of side of the topic, which is bleeding, and I just want to ask Shabneez, a very good presentation, especially its utility in reducing the factor concentrates and other blood components as well when we use it. Just wanted to ask you, because I have practically no experience of using it at our center because it's not available. So I just wanted to ask you about its availability and how much does it cost?
Well, so there are two ways we can prepare it. Either you can do it at your center, or you can get it from the market. So in market, it comes at a cost of 2,000 rupees, Pakistani rupees, for one. And if you want to prepare it in your center, you just need to take some thrombin, some calcium, and take some cryoprecipitate, and you can prepare it in your own center. So the cost is markedly reduced if you prepare it right then and there. And it's easier too, because you have an availability of blood component, you have the reagents, you have calcium, so it's not really difficult. You can do it at the bedside of the patient.
So you were using the commercial one? You were using the one?
Yes, thrombin, yes, because it was topical. We used commercial one. Actually, it was something which was donated to us by the company, and we just thought to use it that way. There were no complications. It was topical, so it was not. It was effective. So the main purpose was to hold bleeding for a while, because the dentist used to say that if the patient is bleeding, we will not touch a bleeder. Right. So we thought we'll just hold on the bleeding for a while, and then we'll get some window period. And during that time, because the glue comes off after a week, within a week, before that maybe.
Oh, right, good. Munira, have you got any experience of homemade or in-house preparation of fibrin glue?
Yes, we also have a very good experience of using the in-house fibrin glue, and it's very cost effective, I would say. because commercially available is expensive, and we also use the same thrombin preparation in-house and the cryoprecipitate similarly like the Shabneez showed in her presentation, 2 syringes filled and simultaneously flushing that over the external surfaces. It's very effective. We also use in our circumcision patients as well in hemophilia
Right.
and other bleeding disorders.
Thank you. Thank you.
And similarly, I just wanted to add about the emicizumab, Hemlibra. So far in Karachi also, we have a very good experience with our 17 patients enrolled in this study. And so far, we don't have any breakthrough bleeds in all our patients, inhibitors and without inhibitors. So far, only few side effects have been noted, but these are very much minor side effects, not much like breakthrough bleeds or like this. So patients are very much comfortable with this product, and they think it's like a magic drug for them because they have to come less to the treatment center only once a week for the loading dose and then once a month for the maintenance dose. They are quite happy with that.
Yeah, yes, I agree. We have a similar experience also. And then now a lot of other patients who are not on this, they're actually coming over that why are these getting this subcutaneous injection and we have to have it, our children have to have it intravenously. So they are getting quite jealous. We might have to get more emicizumab for our patients.
Similarly, more patients want to be enrolled in that study now.
Dr. Mannan, we have got about 11 or 12 patients. I think Karachi has got about 15 patients, and Lahore have got another about like 20 patients. So quite a few patients are on emicizumab now, and we will be sharing our experience after a while.
So what will be your long-term plan? Like whether like is there is any Hemophilia Society of Pakistan is planning to negotiate with them for the long-term use, because if they are on trial, definitely
we have a Hemophilia Society in Pakistan, and there are Hemophilia societies in major cities like Karachi, Lahore, Rawalpindi, and Peshawar. And at present, as I said, we are now getting it free from donation from the World Federation of Hemophilia. No long-term plans as yet because it's something which is extremely expensive. But we'll see how we go, and maybe we'll able to twist somebody's arm and keep on getting it for our patients.
So like recently I was
for 1 year now.
Yeah, we will be getting it for 1 year.
Can you?
Yes.
Yeah, the recently like I was making a cost comparison analysis, and literally like when we share our all wheels data, and my data manager, he came up with this, that the cost of Hemlibra, which is basically prepared by the UK Hemophilia Doctors Association, and after the negotiation, that is costing in a year maybe like around 4,500 expensive than the patient who are on the recombinant coagulation factor, the factor 8. So that was that is a bit satisfying feeling for at least my trust's financial board to allocate us some funds at a decent level to move my patients gradually from this to. So I think it is doable if like people can negotiate and to tell like the Roche to reduce the price to this level, which is comparable with the recombinant factor. I think we have all the abilities that we can do it in Pakistan as well for the long-term use.
So we will include you in our team of people who want to negotiate the price for Pakistan, being a Pakistani.
Yes, I am ready. I am ready to help you people.
Okay, great.
I'm ready to help. Okay, then I have to actually start my clinic. I have to leave. Thank you very much for your time and for giving me the opportunity.
Thank you very much. We would like to see you when you visit Pakistan, inshallah.
Sure. Thank you.
We have come to the end of this session, and on behalf of organizers of HAEMCON 2021, I thank all the speakers for their well-rounded and discerning talks, and our worthy panel members for honoring us with their presence. Thank you so much.